Friends, I am a vegetarian, not because I love animals, but because I hate plants. The subject is quite tedious, awesome, and to say the least, it's slightly boring. But the problem is, whenever we are encountering a shoulder problem, we come to the same attitude, whether treat it or leave it, whether to love animal or to hate plants. People say honesty is the best policy, but by exclusion, dishonesty is the second best policy. So these are the data, and data have their importance. And you can see the fractures are usually in old people, the adults which have a high velocity trauma have the bigger fractures, more vicious fractures. But 80% of the fractures are to be treated conservatively. We treat 80% of fractures operatively. I told you, dishonesty is the second best policy. Complex displaced comminuted fractures comprise 5 to 7%. While understanding fracture, it's nice to understand the anatomy. The scapula, the clavicle, the coracoid, the head, lesser, greater tuberosity, bicipital groove. This is end-on view of a scapula. Again, the same structures. Again, the same structures. The muscles around it, supraspinatus, infraspinatus, and biceps. The upper end of humerus, many a times the head goes into avascular necrosis. The reason is its blood supply. This is axillary artery, this is anterior humeral circumflex, this is posterior one. This is the ascending branch, this is the arcuate artery. So this trifurcation is very important. And there is data that if this is long, metaphysics more than 8 millimeters, and if the medial hinge is not disrupted, probably the head will survive. Again, for understanding an X-ray, there are so many things. The injury occurs basically due to traction, hitting the head with the glenoid or with acromion, or when there is medical problems like seizures or electric shock. As for understanding the fracture, treating the fracture, and assessing the results, there is always a classification. OTA classification, then this is Neer's classification, and this is Codman's classification. These are the types. This is undisplaced fracture. There are fractures at many places, all are undisplaced. So undisplaced fracture is known as one part fracture for the shoulder. Any fracture which is displaced more than 1 centimeter or angulated more than 45 degrees are displaced fracture. So this is one part fracture, this is two part, this is two part with lesser trochanter, this is two part with head and shaft, this is three part, head, GT and shaft, this is again three part, head, greater trochanter, lesser trochanter and shaft, this is four part, all the four displaced or angulated more than 45 degrees. This is again dislocation. Head is here. These are the cases which are bad cases. Now, whenever the patient comes, we have to examine the patients and take care of history, physical examination, and seeing by manipulation whether there is transmitted movement or not. There are different X-rays. There are three main X-rays. This one to be done in the emergency without moving the shoulder because by moving the shoulder we may jeopardize the blood vessel. The treatment, we have general consideration. One is patient's consideration, fracture consideration, and surgical expertise, and the assessment of outcome on clinical, radiological complication and expectations. Non-operative treatment. The indication is a non-displaced fracture. As I told you, 80 to 85% of cases are treated conservatively. The operative treatment, which takes the main swing nowadays, every Tom, Dick and Harry surgeon comes and treats it, is to be done primarily by the minimal invasive techniques, by close manipulation, percutaneous pin or screw fixation, and arthroscopic reconstruction. Then minimal invasive plating or intramedullary nailing or by external fixation. These are the different types: percutaneous pins, suture, K-wire, flexible nails, buttress plates, selected lock is it, IM nails, blade plate fixation. So this one, by wire, fix it by wire, fix it by another wire, wire with tension band. This is rush rods with screws, tension band and multiple screws. Again, this is a buttress plate. This is an angle blade plate, obviously made by the surgeon. So if there is a fracture with some twist, rotation and valgus impaction, this can be treated by putting K-wires and making it fixed with external fixator. Again, if the case is delayed, still you can manage it by minimally invasive techniques, by putting K-wires, and to prevent the wire migration proximal and distal, you can put a X-fix on it. Again, put X-fix, the patient is quite happy, mobile, but there are various ways to skin the cat. There is another treatment, that is locked intramedullary nailing. Initially we used to put a reverse K nail and lock it here so that it doesn't come out. But with the time things changed, we put a guide wire under image intensifier, fracture here, fracture here, fracture here, 1, 2, 3, put a rod like this. This is proximal humeral locking nail. Lock it here, lock it here. Whenever you lock it, there is a problem whether this will allow abduction or not. But if you do it like this, done by somebody else, there is limitation of abduction. Therefore, the entry point should be on the articular surface, go inside, fix it and lock it. There won't be any problem in abduction and the fracture unites well. Final union. See, if the fracture is like this, gunshot wound, again image, and final wound, 1, 2, 3, 3 stitches. Entry point should be here, it should be buried, and there won't be any problem of abduction. See, this is exit wound of gunshot, this is the 3D reconstruction, spiral CT, different screws to fix it, go through image, take the nail, use it as a joystick for reduction and passing through the distal hole. And finally, goes, put the zig, put everything, screws, and again, 2, 3 holes, the arm is stable. Again, locking nails, this is the patient. And see Kanhaiya ji, how he is lifting his arm with a simple nail. So the nails which fell into disrepute, in good hands with judicious use, can give a very good result. Again, you put in a nail, say, many times the proximal fragment is in varus. Put a wire, use it as joystick, pass a nail, lock it, and finally, this is the arm, this is the fixation, and this is the result. Nowadays, there is a great stress on